Second. Okay, there we go. For today's topic, we'll be reviewing the new recommendations for medications for mitochondrial disease. This has been a hot topic in the mito community for the past few weeks, so we are thrilled to have Dr. Amel Karaa with us, who was an integral part of pulling together these new recommendations. Just a few housekeeping items before we get started. Today's presentation will be recorded and available on the Mito Action website over the next few days. If you're joining us via phone, I would encourage you to follow along with the presentation slides that can be found on our website at www.mitoaction.org/resources/safety of drug use. If you're joining us via computer, you should see the presentation directly on your screen. So as we go through today's presentation, if you have any questions, feel free to submit them using the Q&A feature on the bottom of your screen. You can access that on the menu bar at the bottom of your screen, as I said. If you're calling via phone, you can email your questions to us directly at info@mitoaction.org, and we'll open up for questions at the end of the presentation. So we are excited to have with us today Dr. Amel Karaa. Dr. Karaa is a board-certified internist and clinical geneticist and director of the mitochondrial disease programs at Mass General Hospital in Boston. She received an international baccalaureate in biology and chemistry, graduating magna cum laude from Franzo Zichez Gymnasium in Berlin, and a medical degree graduating summa cum laude from the University of Medicine and Pharmacy of Tunis. She has also completed her internal medicine residency in clinical genetic and metabolism fellowship through the Harvard-wide programs. She received the 2013 UMDF fellowship and is currently overseeing clinical care for pediatric and adult mitochondrial disease patients and conducting clinical research and clinical trials for mitochondrial disease. Dr. Karaa was elected president of the Mitochondrial Medicine Society in June of 2018 and sits on the scientific and medical boards of both Mito Action and UMDF. Dr. Karaa is also a founder and board member of the newly launched Mitochondrial Care Network, a US-wide network developing centers of excellence for mitochondrial disease, and a principal site investigator for the North American Mitochondrial Disease Consortium. She is committed to being an advocate for her mitochondrial disease patients and their families, to educate healthcare providers in recognizing and treating mitochondrial patients within the community, and to be a catalyst for bringing a much needed cure to this population of patients. As I said, Dr. Karaa was an integral member of the team that wrote the most recently published paper, redefining the recommendations on the safety of drug use in mitochondrial disease. Please join me in welcoming Dr. Karaa.
Thank you, Karaa, for that lovely introduction, and good afternoon, everyone. I'm very happy to be here today to talk to you about this recent publication. I do have to apologize. I'm getting over a cold, so my voice can be a little raspy and I might have some coughing. So bear with me when I take a pause to sip some water. So I think that this topic is a very important topic, and I'm glad that Mito Action has given us the opportunity to share this information with the Mito Action community and the mitochondrial disease community. We felt, as clinicians and doctors taking care of mitochondrial disease patients, that there were several lists out there of drugs that were listed as being toxic for mitochondrial disease patients. And those have been written many years ago. And we now in 2020 felt that it was long overdue for us to revisit these lists out there and to come up with a more accurate list of medication and information. So this was really the genesis of why this publication was put out there, and why we felt the need to come up with a new list of medication. We also anecdotally, while talking to each other, have heard of instances where some life-saving medication have been avoided in certain patients who needed it in a very acute situation. And we felt that it was very important to establish with more scientific rigor whether or not some medication that that need to be used in certain situations might have a benefit despite being a little bit toxic to the mitochondria. So the list that we provide in this publication is a list of medicines that should be avoided or used with caution in people affected by a primary mitochondrial disease. But even if you don't have a definitive diagnosis and you have a suspected mitochondrial disease, or you're being worked up for mitochondrial disease, or you have features in your testing that tell you that you have some dysfunction in your mitochondria, you may use this list as well. So it's not just for patients who have a primary mitochondrial disease. So I'm on slide 3 for those joining us over the phone, and I just wanted to reiterate why this list of drugs to be avoided needed updating. Again, I said it was, we saw that the existing list of medicines thought to be unsuitable or contraindicated in patients with mitochondrial diseases was very long and contained drugs that we felt could be useful in treating patients with mitochondrial diseases in certain situations, especially in the acute care setting when they are very sick. Therefore, we thought it was important that each medicine on the lists that were out there was reviewed and updated with the latest clinical and scientific evidence. Sometimes I also hear from my patients digging through the internet about foods that are listed as being toxic, like beans or things like that. And so this is an important opportunity to also revisit these. So the way these recommendations were developed was through a very long process. This was a project that was put together through the International Mitochondrial Disease Support Group, IMP, and it was done with our European colleagues. Dr. Michelangelo from Italy and Dr. De Vries from the Netherlands came together as facilitators. And for those joining us over the phone, we are on slide 4, where I'm going over how this process unfolded. So Dr. Michelangelo and Dr. De Vries put together a list of experts in clinical mitochondrial disease medicine and invited about 16 doctors. We were 13 medical doctors. We had 2 pharmacists and 1 basic scientist that joined us. The basic scientist had a specialty in toxicology. So he was someone who worked in the lab by reviewing cell models and animal models and doing those experiments that you read about when we put certain doses of drugs on cells and inject them in animals to see how toxic they are. And we felt that it was important to have disciplines that were widely varied, because we wanted to really make sure that everyone who had knowledge about how drugs work, the pharmacologist and the toxicologist, as well as clinical experts from several specialties, including neurologists, neurogeneticists, internal medicine doctors, pediatricians, who were experts in mitochondrial disease, be involved, because they also contributed a lot of their medical knowledge and expertise over the years, prescribing these medication to their patient and also seeing the effect of those medication directly on patients. And so the way things worked was that we all reviewed the lists of toxic medication that were available online. There were about 50 of them. And then we decided on the ones that we use the most. Of course, over the years, certain medication were taken out of the market, certain medication were no longer available. And so we reviewed the medication that we used the most. We tried to add on to these lists. And sorry, if a medication that we used in the clinic was not represented. And then we came up with a final drug list of 46 different drugs or drug classes. So certain classes like antibiotics, for example, had in them several antibiotics. And for example, anesthetic, there were a lot of anesthetic within this category. And then each of the experts were given a list of 2 to 4 drugs that they had to do their homeworks on. And the homework included reviewing all the literature published out there in terms of the use of this drug, whether on cell models, on animal models, or in people, whether they had mitochondrial disease or not. And then we had to review all of this literature, and we had to summarize all of these findings in sheets that explained what the drug was, what the dose of the medication was, and what how it was used, and what side effects from these medications were found, and whether or not there was a specific indication that these drugs were toxic to the mitochondria, and if so, how. And so we all had to do our homework and write all of these summaries. And then from these summaries, we had to develop questions to the rest of the panel. And then Dr. Michelangelo and Dr. DeVries put together a survey with all the questions and sent all those summaries and all of those questions to all 16 panelists. And then we had to review all of the homework and had to answer all the questions. And then after answering all the questions, all our answers were tabulated. And if we agreed on the answers for these questions, then we were deemed to have reached consensus on a certain drug. And if we didn't agree on our answers, then we were deemed not to reach consensus on these drugs. And so after this first round, we only reached consensus on 6 of these drugs, meaning that when we reviewed the summaries and answered all the questions, we felt compelled that 6 of these drugs were either deemed safe or unsafe categorically, and then the 40 other drugs or drug classes, we were not very convinced, either because we didn't understand something or we wanted more clarification. And so all of this was done remotely. And then the second phase included us getting together face-to-face. And so for 2 days, we were locked down in a room, and all we did was talk about these drugs and review all those summaries and all those publications and all the data that we had found. And so after we talked about it extensively, we again reviewed, came up with new questions. We answered those questions, and at the end of the answers, we had reached consensus for all the 46 drugs. So as you can see, this was done over a long period of time. We tried to be as diligent as possible, and we tried to be very thorough in deciding whether a drug was safe or not safe to use. And so what were the conclusions after all that work? Well, after thorough review, we concluded that most drugs on the previous lists that were available could be used safely in people affected by mitochondrial disease. And you will find on the MitoAction website, and I know Karaa can tell you at the end of the presentation where to find this specifically, the list of these drugs that were considered to be safe and the ones that considers to have special consideration. So I am on slide number 6, and as you can see on table 1, there is a list of the category of medication that we reviewed and their generic name, meaning the name that might be legible on your bottle when it is prescribed by the doctor. So you can see here a wide range of drugs, including blood pressure drugs like ACE inhibitors, pain medication and anti-fever medication like Tylenol and aspirin, anesthetic drugs, drugs that will treat your heart rate, antibiotics, diabetes drug, anti-seizure medication, drugs that are used to treat mental health like depression or anxiety, drugs to treat viruses like the flu medication, a drug to treat bone like the bisphosphonates, cannabinoids, chemotherapies, alcohol, drug to treat lipids or high cholesterol like the fibrates drug, immunotherapy, non-steroidal anti-inflammatory. So this is your ibuprofen, your naproxen over the counter, the statin, and the steroids. So all of these medications that are on table 1, we felt were considered to be safe to use in patients who had a mitochondrial disease. On slide number 7, we have a table number 2 that points your attention to drugs that are prescribed in patients with mitochondrial disease and who might be taken seriously or had certain warnings about them. And these include valproic acid or sodium valproate. This is a medication that has been very commonly used to treat seizure disorder in the past and is still being widely used. It's a cheap drug, so it's usually the go-to medication in certain countries. This medication, however, should be used only in exceptional circumstances when you have mitochondrial disease, because there have been reports of some toxicity using valproic acid. And this drug should absolutely not be given to patients with mutation in a gene called POLG, P-O-L-G, or polymerase gamma, because these patients can have a very fast liver toxicity and may need a liver transplant right away. So this is a life-threatening situation when you have liver toxicity from a medication. So every patient who has a definitive polymerase gamma or POLG or POLG mutation or has a POLG disease should not be taking valproic acid. POLG disorders can sometimes be referred to as ataxia neuropathy syndromes or MIRAS, or they can have several acronyms. So this is something to keep in mind and to share with your doctor. Aminoglycosides, which is the second drug that needs to be cautiously used. It's an antibiotic. It's a strong antibiotic and a wide spectrum antibiotic, meaning that it is usually used for severe infections. And what we know about this drug is that there are specific mitochondrial DNA mutations that can cause hearing loss. And so in certain people who carry these mutations, who are predisposed to developing hearing loss early on in life, if they are given aminoglycosides, they tend to develop hearing loss quickly or acutely when they are on treatment. And so these mutations should be looked for if someone needs to be treated with aminoglycosides for a long period of time. And their doctors need to be aware that this risk exists. I'm sorry. Okay. So, however, we also think that if a mitochondrial disease patient found themselves in a situation where they have a severe infection that can sometimes be only treated with aminoglycosides, then the risks of being treated with aminoglycoside to save their life outweigh the risk of potential hearing loss. So again, these situations have to be considered on a case-by-case basis with your doctors and depending on the situation. The third precaution is patients who have neuromuscular disease from their mitochondrial disease. When they undergo anesthesia, where a blocking drug needs to be used, for example, when they need to be intubated for their anesthesia, usually the anesthesiologist injects them with a drug that relaxes their muscles so that they can pass the tube in their throat pretty easily. So if patients have a muscle disease and they have to be intubated, the anesthesiologist needs to know about the mitochondrial disease and needs to take precaution when using these drugs, because there are certain precautions that the anesthesiologist knows about that need to be taken in these instances. And now in specific situations, we need to pay attention to how we use certain drugs. Not that these drugs are going to be toxic, but maybe because the patient has a mitochondrial disease, their metabolism is going to be different in processing those drugs. So when a mitochondrial disease patient undergoes general anesthesia or surgery, this is a huge stress on the body of anyone, regardless of the underlying disease. And so having the patient fast for long periods of time before the surgery and having the surgery go on for a few hours, and maybe having prolonged anesthesia during the procedure is going to put patients with mitochondrial disease under more stress, and the body is going to crave energy. And so in these situations, the doctors, the surgeons have to be made aware of the presence of the mitochondrial disease so that they can take extra precaution with fluid hydration and giving the patient enough calories throughout that fasting period and in the recovery period. The duration of the treatment, any treatment, can cause extra toxicity on the body. So when you take an antibiotics for 6 or 7 days, is different than when you take an antibiotic for 15 days or 30 days or 6 months. And so side effects may develop the longer you take that medication. And so for each individual needing to go on a long period of treatment, that needs to be discussed with their doctor, and more oversight needs to be taken while the patient is on that drug for prolonged periods of time. The kidney function also, so how your kidneys work, can impact how long the drug stays in your body. So if you have some kidney problems, maybe your kidneys are not as good as filtering that drug out of your body, and that drug might stay longer in your body, and the longer it stays, the more side effects it can cause. And so the doctor prescribing the drug to you needs to know to adjust the dose that you are on if you have some kidney problems. And then finally, if you have high lactic acid at baseline, then extra caution needs to be made at monitoring that lactic acid level if you are put on a drug that might increase your lactic acid further. So there are certain antibiotics like the linezolide or metformin that treats diabetes can cause elevated lactic acid. So if you have a baseline high lactic acid, then your doctor needs to pay more attention to that level and monitors it as you are on taking that medication. So it is always important to remember that any drug can cause any side effect, and that we are all different human beings with different metabolisms. So any of us, even without having a mitochondrial disease, can develop side effects from a medication, because medication are not just toxic to mitochondria, they can be toxic to many different components in our body. And so regardless of whether you have a mitochondrial disease or not, extra caution needs to be taken in terms of making sure that you don't have a risk of developing a side effect for other reasons. But when you have mitochondrial disease, we find that most of these drugs are safe, can be safely used in mitochondrial disease population, and that the same precaution that you would take for any other patient using any medication should be taken when you have mitochondrial disease. And the reason we feel that these medications are safe to use is primarily when we compared all that data that was done in labs using cells, using animals, and using small clinical trials when we could find any, showed that the doses that have been used to assess toxicity to the mitochondria are usually 10 times, 100 times, 500 times higher than the doses used in clinical practice. So for example, if you take a simple drug like Tylenol and put 500 times the dose of Tylenol that you would take if you had pain or fever on a cell, that cell is going to show toxicity just because you are overwhelming the cell with huge doses of the medication. And so that publication might say, hey, we put Tylenol on a cell and the cell showed that there was mitochondrial toxicity. But that's true because you only have one layer of a cell and you put a lot of medication directly on that cell. But when you try to translate that information into a human being, you can't really translate that because, first of all, a human being is not a one thin layer of cells. It's trillions and trillions of different cells. You usually don't put the drug directly on these cells. That drug has to go through your mouth, through your stomach. It's degraded by the acid in your stomach, and a fraction of that dose is going to get to your cells. And so you can't just say, well, Tylenol is toxic to mitochondria, because that doesn't really translate into real life. And so for this reason, when we really went back and reviewed where this information came from, that certain drugs were toxic, most of that information came from studies like this, where there was a small range of either normal cells, not even cells from patients who had mitochondrial disease, or described in patients who had 10 different problems and were usually in an acute situation where they had to undergo surgery or had sepsis because they were infected and were in severe metabolic derangement at the time, and were taking many, many drugs at the same time. And the conclusion of these papers would be, well, this drug is toxic to the mitochondria, which if you really decorticate and look into the details of these papers, you can't really translate those basic science experiments to the full human body, when we know that the doses that we are using clinically are much, much smaller than the ones that were used in these studies. But also when you have patients that were described that have 20 different drugs taking 20 different drugs at the same time and having acute problems, you can't really tell what drug caused the problem and whether those problems were caused because the patient was acutely sick or not. And so when we systematically delve deep into all of this literature where this information originally came from, we realized that when you try to extrapolate from that to what's really going on in patients with mitochondrial disease, you can't really do that. And for that reason, a lot of these drugs were deemed to be safe. But also, we relied heavily on our own experiences. Amongst the 13 clinicians that were in the room, we had hundreds of years of experience and we saw thousands of patients. And we felt that what we were seeing in our clinics went against what those tables and toxicity reports have shown, meaning that a lot of our patients were taking drugs that were deemed to be toxic and they had no toxicity from it. And they have been on these drugs for years and years. And so that's why you shouldn't believe everything that's out there on the internet, but that's why it's very important that every few years or so, when we have more information and have the benefit of hindsight, to revisit these tables and these assumptions, to update them and come up with newer, more accurate information. So, and that's why our conclusion is that it is important to remember that side effects can occur with any medicine in any patient, regardless of whether they have mitochondrial disease or not, and that this can affect anyone taking the medicine and may not be related to your mitochondrial disease. It is therefore essential that you take the advice of your doctor and read the information given with the medicine. And of course, depending on what your other health problems are, you might need adjustments of certain medication depending on how your liver functions, how your kidney function, how your lung function, and all of that. And also it is important that typically a mitochondrial disease patient tend to have several drugs at once, and drugs can interact with each other. And so also talking to your doctor about the interactions between your drugs is important, because the drug might not be toxic on its own, but if you combine it with 3 or 4 other drugs, it might become toxic. So why is this list not the same as other lists of medicines to be avoided in mitochondrial disease? Well, as I said, this is a new updated version to replace all previous lists of medicine to be avoided in primary mitochondrial disease based on the latest scientific and clinical evidence that we could find. And what should you do with this list now that it's out there? I think it's very important that you have this list with you and that you share it with your medical team, and that you consult with your doctor whenever you are unwell or in need to have a new prescription written for you. You can share it also with other family members or with your caregivers so that they may have it. You can also share it, take it with you to the emergency department. I think those are the situations where you are more at risk of being given a new drug, and so having this list on you would be handy. And finally, I wanted to say that this is not this is a work in progress, right? The drugs come and go. We can discover many years after a drug is approved that it can be toxic. You hear all the time about the FDA pulling drugs out of the market for this and that. So this is a work in progress, and we have committed to reviewing this list every 2 or 3 years or so to make sure that we don't end up with these obsolete tables out there that can cause more anxiety to the patient and create confusion. And so we from the mitochondrial disease community, experts and doctors and advocacy group, we are committing to making sure that this list stays up to date. But I think we also need help from you to tell us if you take a drug, whether you feel any side effects from it or not. I think one of the projects that I discussed with Karaa would be to try to use the Mito Action app, which allows you to put in your medication and share that with your doctor, that if you are using the app and putting your medication in, it would be nice that if you feel any side effect or any symptoms that you might perceive as a side effect, to note that in the app and then to share it with your doctor. And then maybe in the future, we can have this being used worldwide, and we can capture real time and real life events when you guys take medication and experience problems from those medications, so that we can continue to update this information using real life situation and real life experiences. I think those were all my slides, so I will stop here and take any of your questions, and thank you.
Thanks, Amel. I appreciate it, especially knowing that you have been under the weather. So know how much we appreciate you taking the time to be with us today. So I have a list of questions. We'll get started with those questions. First question is, do you anticipate that the list will continue to be fine-tuned as we learn more about the disease, and perhaps how often might that happen?
Yes. That's a good question. And as I said, we are committed to reviewing this list, and we are actually now talking about when the next meeting is going to happen. We hope to be able to do that every 2 to 3 years. Of course, it's very complicated to try to coordinate multiple doctors on multiple continents to get together for 2 days and block that time to do this. But this list is not exhaustive, right? We have looked at 46 medication, and we are mindful that there are many other medications that need to be reviewed. And so we are planning to continue to expand the list to more than 46 medications, but also to use the knowledge of the future to update this list.
Perfect. Thank you. Thank you. Next question is, does taking the ingredients of the Mito cocktail allow you to have less adverse effects from the medication, or do those ingredients potentially cause for negative reactions with some of these medications?
That's a really good question. And my answer is, I don't know. And I'm saying that because we used to believe that giving these supplements, because they were vitamins that naturally occurred in our body at higher doses, would enhance the mitochondrial function. And that might be true in certain circumstances. But what recent studies have shown that if you give too much of a good thing, it can become a bad thing. So even vitamins that are naturally occurring, if you take too much of them, it can be a little bit harmful to your body. And so that's why we're very cautious about the mitochondrial supplements and those cofactors and vitamins, and we use them with a lot more caution nowadays than we used to do 10 years ago or 5 years ago. It is also unclear how these interact with medications that we prescribe. Our metabolism is a very complex thing, and we don't really fully understand how it works. And I don't think that there have been many studies out there that have combined the use of prescribed medication and supplements. So the direct answer is we don't really know what happens. We assume that it's safe to take those supplements, but I would also caution not to take too high of a dose of these supplements, and to always talk to your doctor if you're combining things, especially if you're taking over-the-counter things. You should definitely tell your doctor about it.
Right. And with the supplements, right, and correct me if I'm wrong, those dosages are very individualized, and that's something that needs to be worked through with your physician.
Exactly, yes. Especially for the pediatric patient, as they grow, their weight changes, and many of these supplements are based on weight. And so different patients might be on different doses.
Right. Okay, perfect. Thank you. What if I have a negative reaction to a medication that is now listed as safe? Is it fair to assume that if I didn't have Mito, I would still have had that reaction?
Well, that's also a great question. So when one takes a medication, they can have several effects, right? So there are allergic reactions. Those are the most life-threatening when you have swelling, difficulty breathing. You can die from an anaphylactic shock, right? There's the situation where you need epinephrine and you need to go to the emergency department. So allergies have nothing to do with your mitochondrial disease, right? People are allergic to different things, and we don't really understand why certain people are allergic to certain things, because our bodies and our genetics and our metabolism are so unique. Each of us individually reacts differently to medication. So any of us can have allergies to medication. And then you have medication adverse effects, meaning that your body is also unique in its metabolism, and so you are clearing or using that medication in a very unique way in your body. So certain people, for example, clear medication very quickly from your body. Certain people clear them very slowly, and certain people have those medications transform into different other things. And so because of these differences, certain people may develop adverse effects. So these are not allergic reactions that may kill you, but these are things where you can feel lightheaded or nauseous, or you may have a rash, or you may have diarrhea, or, those are what we call adverse events. So these, you can still take the drug if you can tolerate those adverse effects. The drug is not going to kill you, it's just going to make you feel a little bit miserable because you're having these adverse effects. Mitochondrial toxicity can cause some adverse effects, but I think in general, people worried about mitochondrial toxicity because they felt that if a drug is toxic to the mitochondria, meaning that it can further make your mitochondria dysfunctional and inhibit further energy production or further normal function of the mitochondria, that you might feel more tired, that your baseline underlying symptom might get worse. That's what mitochondrial toxicity was all about. So we didn't want to make you feel worse by giving you a drug to treat one symptom, and now your overall is worse. So those are the different problems from the side effects. So I cannot answer your question specifically because I don't know what your reaction was. If it was an allergy, then this changes nothing. You're still allergic to the drug regardless of your mitochondrial disease. If this was an adverse reaction, it depends on what it was and whether you are able to tolerate it. If this drug would be very beneficial to you, again, weighing in the risks and the benefits, which is what every doctor has to do in any situation, I would suggest that you talk to your doctor about this to try to, and give him this publication and the new list and see what you can work out together.
Okay. Thank you for that. I appreciate it. The next question is, I see propofol is on the list. Does that mean it's considered okay even for extended infusions with no restrictions?
So propofol, we do talk about propofol in the paper specifically. It's not clearly listed on the table, but we felt that propofol could be safe to use for anesthesia induction and for short surgeries. The question is, what is a short surgery? Are 3 hours short? Are 7 hours short? And I think that's a question to discuss with the anesthesiologist and the surgeon. So we think that propofol can be safely used to induce anesthesia, meaning to put you asleep. But then, depending on how long the procedure is going to take, your anesthesiologist may make the decision to use it or not to use it, depending on how long that procedure is going to be like.
Okay, great. And so the next question is, can you give some examples of drugs that make the blood acidic, which should be used with caution in lactic acidosis?
Yeah, so like I said, metformin can cause increased lactic acid. The linezolide, one of the antibiotics that is used usually as a last resort for very resistant bacteria, can cause lactic acidosis. A certain, for example, certain ringer lactate, we usually tell patients not to take it because it includes lactate. So it's not going to cause you a lot of harm, but your lactic acid may increase. And I know surgeons like to use ringer lactate a lot in emergency situations. So these are pretty much the ones that I can think of on top of my head now.
Okay, great, thanks. So that was our last question. And I would just say to anybody, if you think of additional questions after the presentation, feel free to send those in to us and we can pass those along to Dr. Karaa. So thank you, Dr. Karaa, for helping the community better understand these new recommendations. As she said, they're posted on the Mito Action website. If you just go to www.mitoaction.org and search drug safety, it'll take you right to the link for these updated recommendations. So I would encourage you to do that and take a look at those lists. And if you're also interested in connecting to the Mito Action mobile app, you can also go to the website and just search mobile, and it'll take you to the form to sign up for the Mito Action mobile app. So I know this presentation represents a significant change for the community, but I hope today's presentation helps to clear up any questions that existed. So on behalf of the mitochondrial disease community, Dr. Karaa, I want to thank you for your tireless commitment to this community and all you do to support our families. We are incredibly lucky to have you. So thank you
for having me.
Absolutely. So as a reminder, today's presentation will be posted on our website for anyone who would like to listen again, share with others, or go back at a later date and listen again. It will be posted probably by Monday or Tuesday, so check back then, and we'll also post on social media when it's live. So thank each and every one of you for joining us for today's monthly Mito Expert series. You can find all of the presentations in this series on our website. Have a wonderful weekend, everyone, and we look forward to you joining us again next time. Thank you so much.